welcome you all to today's session. And today we are here to clear some of our doubts related to our child's sleep and similar matters from Dr. Adil Muhammad, who has done his MBBS and MS in ENT, both from AIMS. He's a consultant ENT and head neck surgeon at Dr. Shafi's ENT Center, which is located at Alua. And I'm also happy to say that he's our fellow parent, just like all of us. And Adil, happy to have you here. You can go ahead.
Hi all, hi dear parents. First of all, I know it's a different topic, and normally we take classes for undergraduates, medical students, and postgraduate students. So it's a difficult task to take class for a not class or session for parents. It's very natural for us to use medical languages, medical terms in between. I hope you will understand. If you have any doubt, you can clear your queries. The last, you may even stop in between also. Everything is fine. So let's begin. Myself, Dr. Adil, I am ENT surgeon at Dr. Shafi's Advanced ENT Center, Alua currently. So let's come to the topic. What is snoring? The first question, what I used to ask you people is, what is snoring? So what is snoring actually? Okay, my slides are visible, right?
Yes,
it is visible.
Okay, fine. So we all know that whenever there is some narrowing in the passage of air through which hello?
yes, Adil, we can hear you.
Okay. Whenever there is some kind of narrowing in the passage of air, and if something vibrates in between, it creates some noise. Okay, so in the same case, in the case of breathing also, if some narrowing is there in the passage of air, or at least if something is vibrating in between, this can lead to snoring, noisy breathing. So snoring, are all noisy breathing snoring? The answer is no. Snoring is only one type of noisy breathing. Snoring actually means whenever there is some kind of blockage anywhere in the nasal part or the mouth, throat, or in the nasopharyngeal region, then we call it as snoring. If the obstruction, if there is some blockage in the airway lower down, it leads to another symptom called stridor, which is not our topic. And other than that, if there is, you might know, if asthmatic patients, they will have a musical sound that is wheezing, which is not related to our topic. So we are not discussing that. That comes under the tracheal, comes below the trachea or the chest portion. Okay, so that's what is snoring actually means. So why is it important? Actually, a specialty of kids or the pediatric population is that kids are obsolete nose breathers. Okay, they breathe through their nose only. You all know the fact that whenever kids have food, or whenever kids, when infants feed, they are programmed in a way that they have to feed through their mouth and breathe through their nose. So the breathing goes on along with the feeding, with intermittent switching on and off. Okay, so that's how it works, and we are programmed for such a process. So whenever there is some kind of blockage coming into anywhere in the nose, that leads to that if kids will stop feeding, or this causes them to, like, they have to take a gasp for air. So that's the difference between adults and kids. So children are obsolete nose breathers. They breathe through their nose only. So the doubt comes that if there is some blockage over here, then why children don't make that noisy breathing during their daytime, and why it's during the sleep time? the reason is that when children sleep, you people, I don't know how many of you have tried this. I used to do this with my daughter, that like I just to check whether she has slept or not, I used to lift her arm and like check the muscle tone. Okay, like children, she is not yet like she is not that matured enough to fake it. So I used to do that thing. I just check her whether her body muscle tone is present or not. So if the muscle tone is gone, that means she is into the sleep. So similarly, there are muscles and soft tissues around the breathe, like nasopharyngeal area. Okay, so what happens is during the sleeping time, the muscles will relax around this region, around this area, the muscles will relax. So what happens whenever there is some kind of narrowing in this region, it will lead to flabby movement, and narrowing of the space itself leads to the snoring in children. Okay, so what are the snoring types? So it's snoring, it can be mainly divided into three types. Okay, so occasional snoring. Studies show that 25% of the pediatric population, the kids will snore once in their lifetime at least. Okay, 25%. It can be more than that. That is occasional. Maybe they have a stuffy nose or a nasal discharge, might be some kind of a URTI. They will snore at that time. Okay, that is occasional snoring, which is very common in the pediatric population, up to 25%. And next is the primary snoring. That is the topic of our day, actually. Today's topic is we wish to discuss this primary snoring thing. And a little bit severe thing is the OSA associated. OSA means obstructive sleep apnea. So obstructive sleep apnea, to just simplify, it is a severe type of snoring or a severe type of obstructed breathing, and it has specific criteria to call a patient is having OSA or not. We have specific criteria for that. Especially like there should be dip in saturation, the oxygen level should go down, or there should be breakage in sleep, and such kind of, there is specific criteria, and for that we have to conduct sleep study and all. We are not going deep into that. Our main thing is this primary snoring. Primary snoring is our children are like snoring for 1 week continuously, 2 months, 3 months, kind of. Okay, without much, without any symptoms of a severe obstruction. Okay, so this primary snoring is seen among up to 10% of the pediatric population, and this OSA associated is more or less like approximately 2 to 3%. Okay, so why children snore? The first question, why do they snore? So there are so many reasons for that. So we'll come into that. Enlarged tonsil and adenoids. Okay, next one is enlarged turbinates. I will tell you what are turbinates. Next is obesity. This is very much familiar. You might have seen cartoons or some movies and all. They show that if a fat person, if a like a bulky or obese person sleeps, they try to portray it as like snoring to show that he's sleeping. So obesity is one of the reasons. Okay, so another thing is nasal congestion, nasal allergy. So what exactly? Do teens come under the pediatric population? Yeah. Teens, pediatric population, actually the criteria is less than 12, less than 40. So pediatric population, we can include 14 years in the pediatric population, no issue. Okay, so if you are facing some issues which I am mentioning here, then pay attention. We will discuss it. No issue. This thing I will explain to you why I am including this 14 years in my next coming up topics. Okay, so nasal allergy, nasal congestion. You people might be knowing that some kind of URTI, a little bit of nasal discharge or a upper respiratory tract infection, viral infection. This can all cause snoring. Okay, so what is a turbinate? So you can see a cross section of the nose. This is an image inside the nose. The side wall, lateral side, we say side wall of the nose. Side wall. If nose is like this, then this wall. The side wall of the nose is shown here, and this is the turbinate, which is just a bulge of the tissue. It's a bulging tissue from the side wall. Both the sides you have this turbinate. If those are enlarged, this can be enlarged congenitally. Like it's not very common thing, but allergic kids or adults also develop the enlargement of these turbinates. But it's not a very common thing. But adult population, yeah, it's a very common thing. If they are allergic or they have this allergic rhinitis or such kind of diseases, then they might have an enlargement in their turbinates. Okay, so the turbinates come around here. So if there is some kind of swelling, it will narrow the passage. Next is allergy, nasal congestion I have explained, and enlarged tonsils and adenoids. Okay, so enlarged tonsil will come around this area. You know that when you open the child's mouth, when you open kid's mouth, you can see two ball-like things coming from the lateral side. Open the mouth. Okay, so those are the tonsils. Okay, so next is adenoid. Adenoid is another tissue which is called nasopharyngeal tonsil. It's also a tonsil kind of tissue which is related to the immune system only. All the tonsils, there are so many tonsils. What we see is the palate. Palate, you know, the upper part of the mouth, you can see the arch. That's the palate. So palatine tonsil, that's what we call the normal tonsil. What we see is the palatine tonsil. Okay, the adenoid is another type of tonsil which is called nasopharyngeal tonsil. So adenoid is like very familiar for many of the patients. Many of the patients who have visited at least one time to an ENT surgeon or an ENT specialist. Okay, so if there is some kind of blockage anywhere here or here, and if when the muscles relax during the deep sleep time, this happens. Snoring happens. Okay, so other factors are genetic factors are there. Like studies have shown that these are uncommon craniofacial abnormalities, syndromic children. You might have heard about Down syndrome and all, and other syndromes are also there, which have the tendency of having kids. Those kids can also have snoring and shorter breastfeeding cessation. Those kids who are not breastfed for 2 years, 1.5 years at least, who are weaned off very early. Studies have shown that, but it's not that significant. But still, just for the sake of completion, I have included that. The other one is environmental tobacco smokes, especially if the parents, the father or mother is tobacco smoker, especially when they come and talk to their kids, if they have the smoke content in their breath and all, it can cause. But it's also like studies have shown, but it's not that clear. The evidence is not that profound. Okay, so I just for the sake of completion, I have included in the table. Okay, so adenoid is a similar tissue which is like a tonsil. You might have seen in the mirror for yourself or your like close relative or your kids, that in the throat there are two ball-like things seen from the side. Those are the tonsils. So this is that area. Okay, you can see in the picture, this is that region, and adenoid is the similar kind of a tissue which is seen behind the at the posterior is the back side, the most back side of the nose. Okay, this region. Okay, we say when it is a backside, it's called posterior. That in medical term, that's why I was using that. Sorry. Okay, fine. So this is adenoid and tonsil. Okay, this is adenoid. Okay, so how will we diagnose that? How will we know that our child is having adenoid enlargement, tonsil enlargement? So first thing is clinical. The tonsils can be seen clinically. You don't need any investigation. Tonsils can be seen directly by an expert clinician. If the child is having, like with the cooperation of the child, we can easily see and grade the tonsil and tonsil. Okay, tonsils can be seen very easily. So next is the adenoid. How will we see an adenoid? Adenoid in Malayalam it's called Mookile Dasha kind of. So in English it's called some tissue in the nose or in some mass in the tissue. Okay, so there's some mass in the nose or it's adenoid. It's very common, commonly used term. Okay, so you can see an image there. Many parents come to us telling that my child is having some kind of tissue inside their nose, some mass is there inside their nose. They are very much concerned that they might have read about adenoids. They might have heard someone is getting operated for that. They might have heard some of their parents might have got some of their relatives or someone is having this kind of issue. So they might read a lot about it. And just by seeing this, they come to us seeking the advice that whether we should operate or not. This is not the adenoid. What I told you, this is not the adenoid. These are just the turbinates which are enlarged. Okay, this is not a mass inside the nose. This is a normal thing which has just enlarged. Maybe because the child was having some kind of allergy. Okay, so this is not a big issue. Okay, this is a normal thing. You know, I told that there is some kind of a projection from the side wall. Okay, so this is that projection. This is another projection. There are 2 to 3. There is one more. This can't be seen, or this can't be seen directly. The only thing which can be seen directly through the nose. So when we see from this angle, we can see how it is given in the image here. Okay, and the side image is this. And if the child is having some kind of allergy, he or she can have the hypertrophy. So where is the adenoid located? This is the adenoid tissue. Okay, you can see in your image, you can see in the slide, this tissue is the adenoid enlarged. Okay, this is the depiction of that adenoid tissue. This is the location. You can't see adenoid through the nose. You can't see the adenoid growth through the nose. Okay, at any cost, only some of us might be able to, if the nose is so roomy, we might, some of my HOD used to tell that we can see the adenoid through the nose, but we don't know. My HOD used to tell that, and we believe what he said. He used to tell that we could see the adenoid or the nasopharynx through you should be able to see, but I don't know how practical is that, because it's very difficult to reach. I don't know. He is so experienced, 50 years of experience, so he might be able, but we are not able. We are like most of the 99.9% of the clinicians won't be able to see the adenoid through the nose or neither through the mouth. Okay. So to see this, we have 2 methods. One is X-ray. So you can see this is for you people to know how, like, you don't need to grade that adenoid. This is not a medical lecture, but still, just for the sake of understanding, I'm mentioning. Most of the clinicians tell the parents to get an X-ray or get an endoscopy for it. Endoscopy for the adenoid to assess the growth, assess the enlargement. So you can see there is a bulge over here. The air passes through the nose. Whatever you see in the X-ray, you might be knowing all this. Air is seen as black in the X-ray. Air is seen as black. Okay, so when there is nothing to hinder that X-ray, it will go as black. So you can see the air spaces as black. Okay, these are all this is the nose area. Okay, which is similar to this, and the air goes like this to the throat. Okay, this is the mouth. Okay, we might be able to appreciate. So this is the passage which is narrowed due to the adenoid enlargement. Okay, so you can see the bulge here. Similar, this bulge can be seen here. This is the adenoid enlarged. This might be 80% or 90% obstruction. When it touches to each other, we might even say it is 100%. But 80-90 can be said very easily from this image. 80 is there, 90 I can't tell, but still 80% blockage can be said. So that's how we see through in the X-ray. Next is the endoscopy. Endoscopy, we have to see the tissue at the back. So what we do, we will put a camera. This is a flexible type camera which we put through here, and we can see the tissue at the back easily. Okay, so this is how we see in the camera. Okay, we have to like imagine like we are standing here. We are standing here and looking at the back side. You can see a bulge here. So this is the adenoid. What we say, this is grade 1. This is very small adenoid. Okay, this is very small adenoid shown here. This is grade 1 adenoid. Okay, so that's how we diagnose adenoid tissue. Polysomnography I have mentioned just because for OSA patients that having severe obstruction and their sleep is getting very much disturbed, then we will advise, like we don't generally advise, but still might be required as a like depends on the hospital practices. Polysomnography is not at all required nowadays. Like it can be done according to the situation. Leave it. Okay. So tonsil, you can see there are 4 grades for tonsil also, like grade 1, 2, 3, 4. We say okay when it is seen according to the tonsillar pillar and all. Okay. So you can see how it goes. This is the enlarged tonsils. You can see. Okay, there can be, you might have seen whenever the child is having tonsillitis or some kind of infection there, you can see some white spots over there. Okay, so those are exudates actually. So this is enlargement. If a child is having this kind of an enlargement, like this kind of enlargement can lead to snoring also, and this can lead to like very difficulty in feeding. Child will be having pain during feeding. Otherwise, snoring, noisy breathing, and so many issues. Okay, we'll discuss that. Okay, so these are the this is how we diagnose adenoid or tonsil. Okay, I hope you people are getting the point. Okay, so next is snoring the only symptom? Okay, is snoring the only symptom? No. So this is another image which is showing the area where adenoid is supposed to be, and the adenoid is enlarged here. Okay, so what are the other symptoms? So when the child is not able to breathe through their nose. Okay, whenever they are not able to breathe through their nose, what happens is they keep their mouth open. They start breathing through the mouth. Okay, so the mouth breathing is the result of this nasal obstruction. We are concentrating on adenoid from this point onwards. Okay, so there's the nasal discharge, allergy and all. Okay, those are occasional, that can happen. We are leaving it at this point. Okay, we'll concentrate on adenoid, which is the main culprit. Okay, our patients, pediatric patients, majority come for this thing, for the adenoid enlargement. So we will concentrate on that. Okay, the mouth breathing can be due to the nasal obstruction which is caused by the adenoid enlargement. So what happens is child is not able to take adequate breath, and the oxygen saturation might go down. That leads to OSA. Okay, even if it is not that severe, what happens is whenever whenever the child tries to take breath during the sleep, the muscle tone decreases around here, this soft palate region. You can see the uvula, the hanging thing. Okay, the soft palate, the palate has got a hard area and the soft area at the behind, hard area at the front and the soft area at the back. Okay, this portion is that soft region. Okay, so it might, like if the adenoid is enlarged, this can cause the palate, when the muscles are relaxed, it might fall into this, and this causes the air is not passing inside. The child is not able to get oxygen or like air. Then they will wake up. Okay, then the muscle tone increases. Then they are able to take breath. So gradually, they end up in mouth breathing, and the sleep can get disturbed. Okay, another thing is recurrent nasal infection. You can see through this, in this image, that whenever there is some kind of secretions coming up here, or whenever there is improper ventilation, when the ventilation is not complete, then what happens is this nasal secretions. There is normally like secretion every time in the nose. It will go into the throat and by to the airway, to the stomach, and it gets absorbed. It's not a big deal. There are some kind of mucinous secretion already, like the saliva we have in our mouth. There are some little secretions inside the nose. That's a normal thing. Okay, so what happens is this mucus, the normal thing, which gets which needs to be circulated gets stasis, like becomes accumulated there, and it, because whenever there is some kind of mucus accumulation, it can lead to bacterial growth, and recurrent nasal infections are the result. Okay, and it can end up children may have, like normally children start developing recurrent nasal infections, which is one among the reasons for which because of which adenoid enlargement happens or tonsil enlargement happens. It's like a cycle. The one will help the other will help this one, kind of. Okay, so that's how recurrent nasal infections happen. Next is hearing impairment. You might be seeing a tube here. You might be able to see a tube here. Okay, everybody is able to see a tube, like a tube here. You can see an opening here. Everybody is able to appreciate, right? I hope everybody is able to appreciate the opening here. Okay, so this is a tube which connects to the middle ear. Okay, so you can see like this is a demo of the ear. You might be able to see it's a model of ear. So this is a normal ear. What we generally we can see through this canal, and this red thing is the tympanic membrane, which might be called like tympanic membrane. That's a common term. Okay, so this is the tympanic membrane, and you can see a red thing here. This is a tube, and this thing opens into the posterior. Are you able to appreciate it? Okay, I don't know. I'm not getting any response.
You mean Zoom, isn't it?
Like, are you able to appreciate this red color thing? Yeah, I'm getting some yes. Okay, fine. So this red tube, actually this opens into the posterior part of the posterior means the back side of the nose. Okay, the most back side of the nose, which is this region. Okay, you can see here. You can see a tube opening, and this connects to the middle ear. This is the ear part. Okay, middle ear. I don't know how many of you are able to. This is the tympanic membrane. This is the middle ear part. Okay, this is the hearing machine, cochlea, and all. You don't need to know all this right now, and we'll discuss it later. Okay, so there is a tube. You just have to understand this much, that there is a tube which connects ear, the middle portion of the ear, to the nose. Okay, this tube gets blocked. So normally there is some kind of secretion inside the ear also. Mucosal secretions are there. So it gets accumulated. The ear needs to be ventilated properly. When we do like this, you can feel the ear is popping up, right? Everybody is able to appreciate. Otherwise, try it now. So when you are having a flight travel, you might do this. So to balance the pressure. So ideally, what happens is this tube, the tube which you can see here, this opening, the air passes through it and reaches the middle ear. Okay, so this middle ear pressure is balanced. So this tube is not working. So what happens is there is mucosal collection. There is secretion gets collected inside the middle ear part. It can lead to hearing impairment. Whenever if the air needs to be conducted properly, if it is not conducted properly, it can lead to decrease in hearing or hearing impairment. So these are all symptoms with which children normally, the parents take their children to us. The issue is children won't be able to appreciate the hearing impairment, unlike adults. Okay, so for that we had to do some tests to identify whether there is some secretion or not. We might have to do a hearing test and all. Okay, so we are not going deep into that, but still, I think you might have understood whatever and like you are able to follow. Okay, if you have any difficulty in following, let me know. Okay, I will take your doubts at last. Okay, that will be better. Otherwise, it might get interrupted. Okay, I'll go with the flow. Okay. Okay, next. So what we should do actually. So first of all, let me tell you that we need to treat this. Okay, so what if we don't treat it? We will look into that first. Okay, so what happens if we don't treat it? So first of all, recurrent infections. I told you. Okay, I just compiled everything. So I'm just telling you again. This is the tube which connects the ear to the nose. Okay, eustachian tube it's called. So this can lead to earache, hearing impairment. When the fluid gets accumulated, when the pressure increases, it can lead to ear ache also, ear pain also. Okay. Next is loss of appetite. Okay, children normally, no, everyone, not just children, adults also. We like enjoy the food. The taste of the food is best appreciated when the food is hot and whenever our nose is not blocked. Okay, when we can take the smell of the food, we will enjoy the food better. So children, for children also, if they smell, we can't. If the nose is blocked, how will they be able to appreciate the smell? Then they won't appreciate the food also. They won't take the food. They won't have the food. It can lead to loss of appetite. Another thing is growth retardation. If they don't take the food, there is less energy and the growth can be retarded. Another thing is that most of the energy will be redirected towards I told you, these children will be having recurrent infection. So it is redirected for fighting with the infection and for the immunity to pop up. Okay, next is sleep disturbance. I told you I used to check my child's sleeping status using the muscle tone. Like I used to pull her hand and check whether the tone is there or not. Okay, so similarly, during the deep sleep portion, children get the good sleep, very good. Everybody, not just children, everyone gets their very good sleep during the sleep, like deep sleep portion. Okay, at that time the muscles are getting very much relaxed. So what happens due to the blockage in the breathing, this children are not able to have a good sleep. This leads to sleep fragmentation. This affects their hormonal. This will have an impact on the sleep cycle, and hormonal changes will be there, leading to irritability. Children get irritable and they won't be performing good in their academics. And there are very less studies in Indian scenario, but in UK, US, it has shown a very much correlation with adenoid enlargement and tonsil enlargement. So poor academics is the one among the symptom issue with which parents come to us. Another thing is nocturnal enuresis, which means that bedwetting. Okay, normally kids bedwet till the age of 7, 8. Okay, 7, 8 is a normal thing. Okay, and if the child has stopped bedwetting for a quite few months or years, and later he has it has come again, then that's also pointing towards having adenoid. But I'm not telling that all the children who are bedwetting are having adenoid issues, but this can be one among those. Okay, this is because there is a hormone which is regulating the amount of urine which is produced. Okay, so this is getting affected because of the sleep, because of the body hormonal imbalance. That's the reason why this nocturnal enuresis or the bedwetting reappears or bedwetting happens again. Next is facial dysmorphism. This is facial dysmorphism is one of the most common causes why patient are referred to ENT surgeon. You might have heard in the last one of the lectures, one of the talk by pediatric dentist, I think. So at that time, madam discussed that we will refer to an ENT surgeon for assessing adenoid. The issue is when children they breathe through their mouth. Okay, but the nose is blocked now, so only way they can breathe is mouth. So they start breathing through their mouth, which can lead to protrusion of their teeth. So the classical adenoid faces, you can see here that this is the textbook picture of a typical adenoid face. This is the face textbook picture. Okay, I'm not telling this is a real picture. This is a textbook picture. You can see the upper jaw. The upper jaw is getting protruded. Okay, the maxillary teeth get protruded. The cheek will get dipped. Okay, there is less ventilation in this region. The sinuses, the air cavities inside the cheekbones get less ventilation, so there will be little bit hypertrophy. Okay, it will be less small in size. Okay, this can lead to dipping or the deepening of the cheekbone. Next is the length of the face is more. You can see the length of the face is more than the breadth. So these are all happening because of adenoid enlargement and mouth breathing. Main reason is the mouth breathing. Another thing is malalignment with the teeth. Okay, or the irregularity in the teeth, like two are going like this. Okay, so this is one of the main reasons. children, what I face, what we face regularly is parents, they wait till we wait till 12, 13, 14 years of age, and later they go to a they think that this is something very silly issue. Then they go to the orthodontist, dentist. They will tell, okay, we will put the they won't they will, if the child is less than 15 years only, they will refer to us, telling that just rule out adenoid first. Okay, so people come to us, then we realize that it was because of the adenoid. Then we get the x-ray and we get to see that maybe in the initial stages, if it is in the beginning stage, maybe 7, 6, 8, 9 years, it is very easy to correct the malalignment also. Okay, but after the adenoid correction. Okay, so this is a facial dysmorphism textbook picture. Next is, so you can see this kid is 6-year-old. Okay, this kid is 6-year-old. You can imagine, just make a picture in your mind. How will I don't know whether he or she, okay, look like when she or when, let us assume it is a boy. Okay, when he is 9-year-old, just assume in your mind, make a picture in your mind. So this child was this is how he looked at the age of 9. Okay, so this child was a mouth breather, which he developed for a long time, and later he got consulted and got operated. So already the changes has happened. We don't expect a child of 6 years to look like this. Okay, you can see the malalignment in the teeth, the lengthening of the face. Okay, the cheekbone is little bit depressed, and the breadth is little bit less, but the length is more. You can see the facial, I won't say dysmorphism, but still there is a change. We don't expect the face to change like this for a normal kid. Okay, next is a cardiorespiratory. That's not related to our topic. That's actually for OSA patients. This snoring, especially for adults and OSA, obstructive sleep apnea patients, will have impact with their blood pressure and all, heart functioning and all. So that's very important for OSA and obesity related, maybe OSA patients mostly. Okay, so we are not dealing with that today, so we can leave it. Not for the adenoid enlargement. If it is very severe, only it will affect. If it is very severe and long standing, it may affect the functioning of the heart and metabolism, etc. Okay, so what are the management options? So these are the problems we will face if we don't manage this properly. So what are the management options? First of all, we can see that this is the nose through which we take the breath. This is the mouth through which also we can take the breath. This will go into the lungs. Okay, so you can see a small portion esophagus written over here. Okay, so new studies. These are the latest studies which we had our own study at my institute at Delhi. So we have studied children before and after this adenoid surgery and the acid reflux thing. So what I wish to convey is that acid reflux is not just the acidity issue. This is not a thing just only for adults. Kids will also have, but they won't be able to appreciate it. Some kids might be able to tell that I am having this issue. Some won't be able to appreciate that. So the issue what we see is the consequence that the tonsil and the adenoid enlargement. So there is a little bit of the acid reflux or the acidic secretions will come up if they are having a lot of acid production in their mouth, in their stomach. It will come up little bit through here, and it can irritate it through here, just by the creeping up through the walls of the pharynx. It can irritate the tonsil. It can irritate the adenoids, and this is one among the reasons of having adenoid and tonsil enlargement. These are latest studies. We published our data in last year. So my senior had one of these theses on that. So that's why I don't know how many of our doctors prescribe also anti-reflux measures. So medical treatment. First of all, there is a medical treatment. Okay, first we should give, for all children, we give a trial of medical treatment first. Okay, then the main treatment is the nasal spray. Okay, the acid reflux measure is one among those. The main thing is the nasal spray. We give a nasal spray. There are several types of nasal sprays. some children who have allergy issue, which is a little bit more like if they are having a serious allergic issue also, then we will consider that also. Then the spray might change. Otherwise, we will give a normally nasal sprays are prescribed, and other than that, nasal decongestant to decrease the secretion, the pooling of here secretions here, the tube to get open, and all this. The secretions to decrease, and all the decongestant. The congestion has to be decreased. So decongestant, and nasal sprays are the main modality of treatment. We add anti-reflux measures like anti-reflux medicines. So these are the medical treatment. Next is for the acid reflux, some things has to be considered. So what are the household measures we can follow? First thing is avoid Pepsi, Coca-Cola, chips, Kurkure, Lays, all those fast food things. Okay, the pickles, tea, coffee. So these kind of things you can give Bonvita, milk, Boost, Horlicks, kind of. Those are not an issue. Tea, coffee, kind of. Those are stimulants. It stimulates the stomach to produce more and more acid. Next is lime juice, Pepsi, lime juice, soda. All these which contain soda or carbonated or aerated drinks, those are adding up to the acidity. Already the stomach is producing a lot of hydrochloric acid for the digestion purpose, and we are adding the pH onto it. And the mechanism is meant like that. Like if you add more acid will be produced. It's a feedback loop what is happening in the stomach. Okay, that's programmed like that. So we give like we have to control all this: Pepsi, chips, Lays, Kurkure, then what we say fast food, pickle, tea, coffee. Okay, we can give milk, no issue. Okay, so these are the measures which we have to follow. Okay, this is the medical treatment. So how long we will treat medically? That's the question which majority of the parents come and ask. Okay, he is already under medicine. We can't wait for some more time. The issue is I told you about the complication. So, but still we have to medically treat. We don't advise any of our parents to undergo their children should undergo surgery at the first visit itself. You have to wait. You have to give a course. You have to give a course of medical treatment first, and that for 3 months. Okay, I think I missed a text there. It's for 3 months. Okay, 3 months is the course of medical treatment which we follow maximally. Okay, once the patient come to us, we start medical treatment after assessing and confirming the adenoid is there. Then we give medical treatment for 3 months. Okay, the nasal sprays and this decongestant won't be given for a long time, but still it can be given, not a big issue, but still we give for 2 weeks. Okay, PPA, the acid reflux medicines are given for 2 weeks, 3 weeks, maybe 1 month can be given, maybe given for 2 months also. So that's the 3-month period during which we manage medically. So if it is okay, after 3 months, if the child is symptom free, then we are done. We have got rid of the adenoid enlargement. So what happens if the child doesn't recover completely after 3 months? Even after 1 month, if the child is not showing good progress with the medical course, if we have given the medicine and the child is not responding completely within 1 month, and the symptoms are progressing, or the red flag signs are there. I will show you the red flag signs later. I will show the slide later. Okay, so then we have to go for surgical removal. So that's called adenoid tonsillectomy. So tonsil, we don't operate for everyone. There are criteria for tonsil also. Adenoid, there are red flag signs we have to look into. So if the medical treatment fails, then the next solution is the surgical removal of the adenoid tissue. Okay, some children will have adenoid and tonsil enlargement together, and if it is a grade 3 tonsil or a grade 4 tonsil, then we will do both together at a single sitting. Okay, so otherwise, if it is a grade 1 tonsil or a grade 2 tonsil, then we won't operate that or tonsil always. Okay, we will keep it there. We let it there, let it be there itself. We will do the adenoid, and we remove the adenoid and come out. We will tell that wait, let's wait and wait and watch for some more time. So because tonsil enlargement, it won't make that much of symptoms. Okay. So next, the other things are like positive airway pressure devices. Okay, these are not that much successful. Maxillary expansors, especially given after the surgery, for that the teeth protrusion. So to manage that maxillary expansors, there's a clip-like kind of thing which is given by a pediatric dentist or the orthodontist to cause the space, and this protrusion can be prevented because the bone is still growing. You don't need to put the braces. If you identify mouth breathing early, if you're finding the irregular pattern to teeth growth in the early time itself, you can manage it by getting rid of the adenoid if that's a culprit, or finding the cause for that and correcting it, and with the maxillary expansor itself without the braces and all, you can correct it. I'm not going in detail. So surgical treatment, there are several methods to do this surgery. There is a classical one which is mostly common, which is mostly done in government setups. Also in that, we go through the mouth and we just scrape it off. We extend the child's neck and we scrape it off from here. Okay, that's a blade kind of thing. We scrape it off and it comes out as a chunk. Okay, so there are so many things you should be, like some parents will be already knowing about this. The thing is, the majority of the parents ask us, will this recur after the surgery? The answer is, if you do it completely, if you remove the adenoid completely, the chances of recurrence are zero, like less than 0.1%. So if you remove it completely, I'm mentioning it, but there are several techniques to remove that adenoid. There are several techniques. So one is the classical thing that which is commonly practiced, which is called cold steel technique. Okay, so we remove it through the mouth. We remove it by scraping it out. Okay, next is using another motorized blade. We'll go through the nose and see the adenoid. We'll go through the mouth. We'll go through the nose. We'll put a camera over here and see the adenoid and go through the mouth, and we'll cut it, chop it off, kind of like using a motorized blade. Okay, this is one of the techniques. Okay, so these are motorized techniques. Next is a coblation technique. Okay, coblation technology. So that's the latest thing. There are so many advantages for that. Okay, in that we will just dissolve it or just burn it off or dissolve it off from the wall, posterior, like the backside wall. We put a camera and see here, and we will take out this tissue. We won't take it out as a piece, rather we will dissolve it off, or we will just burn it off. Okay, it's not laser, it's plasma technology. Okay, so I'm not going deep into that. If you want to know, I'll discuss it. I have a slide I have kept, but I'm not discussing it. Okay. Next is sleep hygiene. Doesn't have so much importance, but like for the child's health, so much importance with the adenoid management. But for the normal health of the child, good sleep hygiene has to be advised overall. Okay, so what are the red flag signs? When should you consider surgery very fast? Okay, so if the child is having gasping, or if the child stops breathing while sleeping, if the child is having breakage in their sleep and they're getting up, they're getting like so much difficulty with their sleep, then we have, if gasping is there, then we have to definitely go for surgery. Next is snoring greater than 3 nights a week. Snoring is very severe and very you have to be very severe, and more than 3 nights, like more than 50% of the days of the week, like 3 days in a week, then we have to consider surgery. Then excessive sleep children are not able to sleep during their night. So what happened? They start daytime sleep. So this can lead to excessive sleeping during the daytime, and reappearance of bedwetting. I already mentioned that. Okay, so next is growth retardation. So I used to share one incident. Last month, one patient came. One parent came with their kids. Okay, actually, they are twins. One child is little bit decreased, like less height, and less weight compared to the other kid. They came for this snoring issue, and they were told that this child was born as like less birth weight, and because of that, we felt that this child, the same child, is having all these issues. But the actual reason was that that child was having adenoid enlargement, and we are getting it operated. So that child was having lesser growth because of the same adenoid issue. But we don't get to compare this frequently, okay? Because that child had a twin sibling, we got to compare that, and we understood that, and that's the reason. And he is planned for surgery very soon. Okay, so next is headache. I told you, when the child is not getting proper sleep, then they will end up having irritability and very aggressive and cranky. So that is one among the issues parents complain to us. Okay, next is dropping grades or productivity. I already mentioned this. Okay, so these are the red flag signs. And if the child has completed a 3-month course, then we should definitely go for surgery, which is a best method for the best thing for the kid in this aspect. Okay, so how do we? So this is for the I told you, frequent snoring. So how will we tackle occasional snoring? For that, like there will be some kind of if the child is having some kind of URTA flu, then the secretions get dried up in the nose, and this causes snoring. So this can be tackled very easily by using nasal saline drops, which is very commonly available in the medical store. Okay, so next is remove potential allergens. Some children will be having some kind of allergies, nasal related nasal allergies. So this can be removed. Potential I want there are studies which show that urban population children have more urban population have more allergy than the rural, because during their initial growth period they are less exposed to all these allergens. So I preferably I normally tell, when the children for the kids allergy, you need to mingle more up with this dust and mud, everything, so that they won't develop this allergy later in their life. Okay, so, but for adults, if you are allergic to something, then avoid it. Okay, for kids, we don't tell complete avoidance. Okay, so next is air purifier, humidifier can be used. Weight reduction for obese kids. Okay, obese kids, the best method is weight reduction. Okay, because what happens is obesity it can lead to this snoring issue, and there will be some kind of adenoid with that. We remove the adenoid, child is fine. Then they go into their normal diet habits, which might be like they already have a genetic tendency to be obese. Then with adding with that, the lifestyle changes, leading to obesity, more obese and causing snoring again, the obstructive symptoms coming up again, and they will come and complain. Then we will get an X-ray, we see the patient, and we tell that the adenoid is not there. This snoring is due to obesity. Okay, so for obese kids, we tell, and obese adults also, we tell to avoid snoring, to decrease snoring. You first decrease your weight. That's the main thing. You have to maintain your BMI. And for adults, and for kids, you decrease the weight, avoid junk foods, and good sleep and dietary habits. Okay, so you can see here, this is a normal nasal saline. Okay, don't go for the brand. Okay, the same brand is might be having another nasal drops also. So just see what it is written. Nasal solution. Okay, saline nasal solution you will get from where it's an over-the-counter drug. Okay, over-the-counter drug, you can get it anywhere. Okay. Silometazoline, this drop. Okay, I told you don't go by the name. Okay, saline is the thing which you have to highlight in the for saline drops. Don't go use this kind of nasal drops for kids without the advice of the doctor. Okay, this can cause rebound nasal stuffiness. Okay, so don't use these nasal drops, which is very less advice, especially for less than 6 months of money. We don't give it all. For a little bit more for kids we give, but that's like very required situation only. Don't purchase it over the counter and use it, because it has got its own side effect. Sometimes we are forced to treat the case, like it's treat the complications of this nasal xylometazoline usage, this otrivin usage. Okay, so okay. So what are the what are the take-home messages? So pediatric snoring, the main culprit is the adenoid and the tonsil. Okay, there is some medical management which is for this is for a duration of 3 months. Okay, maximum. Okay, if the child recurs after that, so if the child has undergone a medical treatment, he is fine now. After 2 years, he develops this again. Then we don't advise for medical treatment again. We just tell them, get it operated. You don't go for a second chance. We don't go for a second course of medical treatment. It is best you get operated. Your child will develop it again. It's better you get it off. You get that adenoid out. That's the best solution. So surgical management, there are several techniques. The best one is the coblation technology. You may go into the maybe you can go into our own website and see the videos or know more about it. Okay. So what are the red flag signs? I told you what are the red flag signs. Okay. So those are the things which I want you people to remember. Okay, these are the red flag signs. What are the red flag signs? Are the gasping, snoring more than 3 nights per week, excessive sleep during the daytime, growth retardation, headache, reappearance of bedwetting and all. Okay, so that's all for today. If you have any queries, you may ask. Okay. Tonsil, one more thing. Tonsil, I just want to convey one, miss one slide, I think. Okay, it's tonsil also, like we don't operate for all the tonsil infection. Tonsil infection can be managed medically. Tonsillitis management is medical only. If the child is developing recurrent tonsil infection, or if it is so big for hypertrophy, tonsil infection, tonsillitis, and the tonsil enlargement is different. Okay, tonsillitis can cause enlargement, but the reason for which we operate is tonsil enlargement. The enlarged tonsils are to be removed if it is very big. Okay, tonsillitis will subside with the course of antibiotic. If the child is having recurrent tonsillitis in a year, maybe 7 episodes. If 2 years, if he or she is having more than 5 episodes, if in the last 3 years, every year she is or he is having 3 episodes per year, then we tell them, okay, you get it operated. If it is so big, if it is recurrent infection, or if the child is having some other complication related to tonsillitis, there are so many rheumatic heart patient. If the child is having some immunoglobulopathy like IgA deficiency or IgA nephropathy, there are so many other things. So then we will tell, okay, then we have to get it operated. Otherwise, tonsillitis, we don't need to operate. Tonsillitis, we go with medical management. That's the best thing. We might have to take your kid might have to take a course of antibiotic, and that will suffice. Okay, so tonsillitis, we don't operate that frequently. Okay, but the adenoid, yeah, because of the complications it can have, because of the long-term impact, because of mouth breathing, which can lead to irregular teeth, malalignment of the teeth, maxillary protrusion, and all other complications. We tell them to get it operated if the medical treatment fails. Okay, so that's for today. I'll take your questions. I hope you people understood. If there is any issue, if you have any doubt, then please let me know. If there is some point which you can't understand, if you couldn't understand, you let me know. Okay.
Please post the doubts in the chat box, or you can take the mic and ask.
Okay, I'll go to the first question. Do teens, I answered that. Adenoiditis recur if treated long term with nasal sprays. Okay, so nasal spray. Nasal sprays are not, that's why I told, nasal sprays are not given for long term. Okay, especially for kids, we don't give it for more than 3 months. Maybe like if they are not, they were not using regularly, might give like proper 3-month course is given. Otherwise, you won't give nasal spray for long. If it is, the issue is it can develop adenoiditis. Adenoiditis, I think you might have meant, like you meant adenoiditis only. Okay, so adenoiditis, if the immunity goes down, it can lead to. So I forgot to mention one point. First of all, like the adenoid is a lymphoid tissue. Okay, these are associated with the immune system of the body. Adenoid, tonsil, everything. Okay, so adenoid is needed for the kid till 3 years of age. Till 3 years of age, it plays very important role in the immunity. After 3 years, it doesn't have much role in the immunity. Okay, and removing the adenoid doesn't decrease the immunity of the child. Okay, in the initial phase, actually this adenoid, tonsil, etc., help in trapping all the allergens, all the dust particle, bacteria, virus, everything. They process it and tell the immune system that these are the things which is coming from outside. Should we respond to it? Should we make antibody against it? So all this communication happens. The signal goes from the adenoid. After 3 years, it doesn't have much role with the immunity and the tonsil also, but still adenoid. That's why we don't operate less than 3 unless it is a very severe case and requirement. Otherwise, after 3 years, it's not a big deal to get the adenoid operated. What I'm telling this because by the age of 13, 14, 15, 16 years, this adenoid and tonsil will get subside. Okay, some people that tonsil will remain big for some more time, but children, the adenoid will get subsided by the age of 15. That's a natural thing. Okay, that's a natural thing that it will subside by itself. But the issue is the complications which is related to it. Then you have to get the orthodontic treatment then it will be all the complications like we have to face. So better get it treated in the early phase after in the early phase, because in olden days, okay, even my relatives, the child had tonsil enlargement, adenoid enlargement. So they consulted doctor. At that time, the studies were not that established. So what happened was like they told some doctor told them that okay, it will subside by itself, just wait till the age of 15. Okay, so what happened, the child developed like the protrusion of the maxilla, she got to like the orthodontic treatment, the braces, everything. Okay, so initially if they could have avoided all this if they got it treated early. So it was an old school thought that by the age of 15 everything will subside. But it will have its own implication. It will mark its footprint and leave. Okay, so that's why I told you that 14 years, yeah, it comes under the pediatric population for this case. Next, next.
Just a second. Does it mean that even if the child is not snoring and they are sleeping mouth openly, with the mouth open, then we have to show, right?
If the mouth, if the child sleeps open mouth, okay, if the mouth breathing is there, then we have to identify the cause first. Okay, for that first, normally people do is go to the dentist and tell that we have mouth breathing. So what they do is they refer to us. So you can get a dentist opinion, or like best thing is to get an ENT opinion, because they are definitely going to refer to us. So what we have to do is get an X-ray, like what I showed you. We get an X-ray for such kind of kids. Some dentists refer to us, then we get an X-ray. We then give a report that the child is not having adenoid enlargement. Then so the child is not having adenoid enlargement. So go ahead with your procedures. The issue is the child is supposed to breathe through their nose. The adenoid is blocking. So then, if like the dentist treatment, initially they won't put braces. For the kids, they don't put braces. They start by using clips and the blocking devices. So if the mouth is blocked and the nose is also blocked, then how will the child be able to breathe? Okay, so they won't go with that treatment first. First, they will try to tell them to get an ENT opinion and rule out the adenoid status. If the nose is blocked, then you can't do anything in the mouth. Okay, so first you have to get a confirmation that there is no adenoid enlargement. For mouth breathing, might be like if it is a 10-year-old kid, she might or he might have had the adenoid enlargement during the initial phase, like 3 year, 4 year, 5 year, 6 year, and it has caused the maxillary tooth to expand or the mouth breathing to happen. Later, this might have subsided. This might be the case sometimes. Okay, this can be another scenario where the adenoid was enlarged previously, it subsided, but the child is mouth breathing continuously. This is very common thing which we see in a regular basis. So now what we do is we get an X-ray, we confirm that there is no adenoid enlargement. We tell them, we give a letter to the pediatric dentist, that you continue with your procedure. There is no issue with the adenoid, or else you give a trial of oral, because if the adenoid is very small, it is grade 1 or grade 2 or grade 1, very small, then we don't need to remove it. We can give the nasal spray and send the patient. We tell them you get the dental treatment going on. Give a trial of dental devices. Okay, and if they give the trial of dental devices, or they give they test whether the child is able to breathe through their nose, then they will start their treatment. Okay, normally what happens is breathing through the mouth is very easy. So everybody breathing through the nose is a little bit difficult. That's why we are programmed like that and sent here. Okay, and for feeding also. So if you breathe through the mouth, it's very easy. But breathing through nose, we have to take some effort. So what happens once the child starts mouth breathing, they will continue the habit. So even after the adenoid has subsided, the mouth breathing continues. So for that, we have to get a dental treatment. If the adenoid has subsided, get a dental treatment, get it closed, done. Okay, they get it closed means they get some clips or some treatment for that, and they will give you the devices for that. Then you can continue nose gradually make the nose breathing habit come back. Okay. Next.
Excuse me, doctor.
Okay, I'll take 2 more questions from the chat. I will finish the chat once. Okay. Nasonex. Nasonex is one of the sprays which we give, but we can't give it for a long time. Okay, it's advised, but it's not like I can't tell all the indications for Nasonex here. But still, I will tell Nasonex is one among the sprays which is given, which is mainly for allergic kind of thing, but not for adenoid always. Okay, normal saline drops is fine. You can give it. You put normal saline in your children, like in your kids' nose for 1 year, 2 year, or 10 years. Nothing is going to happen. Okay, normal saline you can put it anytime. Okay, partial hearing. My child is not snoring. Okay, my child is not snoring. That's fine. Very good. 0.65 that. Is sleeping keeping the mouth open to be treated? Child is 6-year-old. She is generally active. Fine. That I answered that, I think. No. Okay, I think Anshat Hussain is fine for that answer. Okay, next is my child not snoring, but he is mouth breather. He keeps his thumb finger in the mouth during the sleep. He is also underweight. Doctors request thyroid function test. They are normal. Thyroid function is fine, no issue. Underweight, it doesn't come under the adenoid, I think. Like child not snoring, but he is mouth breather. You have to get an X-ray first. Okay, we will get an X-ray first for this kid, Muhammad bin Ali. Like we have to get an X-ray first. Okay, we have to find whether he is having adenoid or not. Okay, I told you, all the children who are underweight, adenoid is not the cause. If the child is having recurrent infection, if the child is a mouth breather or snoring, then these are all the things which make us suspect there is a adenoid enlargement. There is some kind of an enlargement in the adenoid. Okay, so thyroid function tests are normal. Okay, fine. You get a pediatric opinion by AC underweight. Okay, there will be some cause, maybe some malnutrition cause will be there. You get a pediatric opinion. If they are referring to a ENT, get an X-ray and visit a ENT surgeon or ENT specialist. Okay, so I don't think your child is having so much of issue. This is maybe just underweight. You have to get treated. Okay. If he keeps his thumb in his mouth, then he won't be able to close his mouth. No? So that's it. Underweight, you have to get the treatment for underweight. That's it. Get a pediatric opinion. More than enough. Next is Harina. Is snoring an issue for middle-aged ladies? Not the topic of the day, but maybe snoring can cause big issues, but it's not a like we can't tell. Like snoring, occasional snoring is fine. There are we have to check whether the patient comes under the OSA category. We have to see what is the reason for snoring, whether it can be corrected, if surgical surgery is needed or not, whether the septum is deviated, nasal septum is deviated or not, if there is some allergy or not, tonsil enlargement. So we have to get an assessment. We have to get a clinical assessment, get a ENT opinion for snoring for middle-aged ladies. Okay, if you are obese, if the patient is obese, then get the weight reduction and all is very much needed. Sometimes he complains breathing difficult early morning. Maybe the nasal secretions are getting dried up. That's the only issue. If the Muhammad bin Ali, he is telling sometimes he complains breathing difficulty early morning. Maybe because of this only. Maybe secretions are getting accumulated in the nose. Maybe dry. You can use saline, or just if you are having doubt of this adenoid, just get an X-ray and get it clear. Okay, just finish that story there and then and there itself. Get an X-ray, confirm whether adenoid or not. Then otherwise, if everything is fine, go with the pediatric treatment for underweight. Okay. 3-year-old child is wheezing, but there is no visible sign of inflamed adenoids or tonsil. I told you, you can't see the adenoid through the visible sign. Means you have to see that inflamed adenoid. You can't see tonsil is not there, but he has stuffy nose, so that's not wheezing. Rarely mouth breathes. Wheezing is, I told you, there are 3 types of most common noisy breathing. There are so many, but still I'll mention 3. One is snoring, which comes from the blockage in the nose, nasopharynx, oral cavity area. And next is a stridor, which is very less, which is a congenital thing, most commonly seen, not a like which not an accurate thing. Wheezing is something which is related to the lungs. Okay, when you have seen some asthmatic patients, like sense a musical noise which is coming, so wheezing is that. Okay, I don't think the child is having wheezing. Most of the kids will have some kind of secretions in their nose, and it gets dried up, and there's some kind of a noisy breathing, which might be confused as wheezing. If you feel that the child is having stuffy nose, then use the saline for a week or something. Then just check whether he is getting relief of the symptoms. If not, then get a pediatric opinion or an ENT opinion. Okay, we rarely know this. Okay, fine. Admila, 1.5-year-old daughter frequently changes position by singing, but she doesn't mouth breathe. Is it okay? Frequently changing position is fine. You have to check whether the child is having any breathing discomfort or not. Okay, if the child is having breathing discomfort, then you might have to get seek opinion. But I don't think this child is having an issue because it doesn't mouth breathe and doesn't have any breathing issue. Frequent changing her position is fine. I don't think that's something which needs to be worried about. 1.5-year-old won't have that much of issue. If the child is having any feeding issues, you have to see. If the child is having feeding issues, then definitely you have to get a pediatric opinion. 1.5-year-old child won't be having much of the adenoid issues. Might be having some kind of a nasal URTA, nasal infection or something. So you have to get it treated. That will suffice. Okay, like frequent changing of position is not a big symptom. Okay, if her sleep is getting broken up, then okay, we might have to consider something. Like we have to suspect something. Okay, it's not a big issue. That's different. My son is 6 years old. He is having recurring wheezing problem. We did take X-ray. We told he has 90% block. He is thumb sucker also. Should we do adenoid removal? He is very hyperactive. He does not listen for more than 5 minutes, even during classes, because of that. I told you this. All the children will be hyperactive. Okay, so children are meant to be hyperactive. They are supposed to vent out their energies. They are supposed to release their energies. So that's like can be a normal thing also. Okay, it's not always the adenoid is not always the culprit. Okay, so first of all, we have to, you told that there is 90% block. Then the first thing is, if the X-ray is there, then we have to get once the disease is confirmed, we have to start medical treatment. What I mentioned, the acid reflux measures, then the nasal sprays we have to start, then the other decongestants we give for 3 months. Once 3 months period is done, if the child is fine, done with that. We are done with that. If the child is not relieved of the symptom, go with the surgery. That's the best thing you can give the child, because it's very it's a very okay. It's a very 20 only 15 to 20 minutes you will take for that surgery, and that 15 minutes is like worth the it will be a game changer for the child. If you consider the latest technology coagulation, it will take 15 to 20 minutes only. Okay, that's less than 30-minute procedure, and you will be like, if the adenoid is the culprit, then you get relieved of all this difficulty by that. I am not giving guarantee about the hyperactivity, because it can be because of the child's nature, or maybe child is having some issues, some coping up issues or maybe crying, like that's why we are in the crying community. Okay, that those people will be better to handle than me. Okay, hyperactivity and all. Okay. Even during classes can be a sign of ADHD. Okay, that you talk to the psychologist or the psychiatry psychology team. I think Maria Madam will help you with that better.
Yes, you can
Okay.
message your doubt to Shruti. She will guide you on how to.
Okay. Okay, sir. Thanks for your kind information. Thank you. Welcome. Thank you, doctor. The session was very informative. It's the same as viewers has. So just to confirm once again, for a 6-year-old sleeping with a mouth open and no snore, he'll have a consultant in India. You just have to get an X-ray and confirm that the child is not having adenoid enlargement. Okay, because if the child mouth breathes for a long time, it can lead to facial dysmorphia. I told you it can lead to protrusion of the teeth. Okay, and later a child might end up in having this braces or the correction thing and all. So better get it. So better you get it confirmed. Just one X-ray is not a big deal. So we do generally we do not do endoscopy for the kids. Okay, so endoscopy can be done as a measure. We generally don't prefer endoscopy for kids because once you do endoscopy, like for kids, if they have to cooperate. If it is a 9-year-old, 10-year-old kid, endoscopy can be done. We have to get the child in confidence, and we can do it very easily. But for a 5-year, 6-year, they like once when you put the scope inside, even if it is numb inside, they will be having some kind of discomfort. Then what happens is later, if the child is planned for surgery also, they will have some coping issue. They won't trust the people who are doing the surgery. Like when they won't enter the operation theater, they won't like come. They will have like it's kind of a psychological trauma. So we better avoid endoscopy for kids. Better get an X-ray. It's just an X-ray. Nothing is going to happen. You don't have to worry about radiation. One radiation is nothing compared to what in the radiation world we are living. So X-ray is a very small investigation. Get it clear. If your child is sleeping mouth open, then just get an X-ray done. Get a ENT opinion. If the X-ray is normal, then very good. Then get a pediatric dentist opinion for the devices and get rid of the mouth breathing. Otherwise, later what happens that when the new teeth come up, after once the milk teeth goes, already 6 years old milk teeth has gone. I think the permanent teeth might have come by this time. So then they will develop all these issues, that the malalignment. Then later at the age of 10, 12, you might end up in like you might have to take the child to teeth braces and other orthodontic treatment. Okay, so better like if you have some doubt, then finish it off as soon as possible, because the world is changing. So we are having all these like technologies and all these things nowadays. We don't have to suffer now. One of the main issues is when the child comes at the age of 13, 14, 15. Like it's very difficult for us to explain to the parents in front of the children, because like 13, 14-year-old kids come, they will have the protrusion of the teeth. Then the pediatric dentist centers, the child is having adenoid. Then we tell them like it's already up to like the stage of getting subsided. So like we can't tell the parents in front of the kids that you should have got it operated at the age of 7, because child might be mouth breather for 6, 7, 8 years, and they didn't get operated in the worry of having a surgery done. And we can't tell in front of the kids that you should have got it operated. Like we feel the empathy, but we can't help at that time, because once the permanent teeth has come up, the bone growth has ended. Then only thing is orthodontic treatment which is remaining. You can't use the spacers. Nothing. You can't prevent that. So we can't tell in front of the kids that your parents didn't get it operated. So that's not the right way. So we feel sorry for that, but we can't help sometimes. Always we can't practice ideally also. So if you have any doubt, you just get it corrected. We have all this facility in our wherever place you live. Okay, so finish that doubt. That's the best thing. Okay, the other.
Doctor, is there an age limit for the surgical process, like such so and so age? Like my son did have an issue like this way with adenoitis, and the thing is, the nasal spray Nisonex was continued for more than a year. And with the audiometry test, we found that there was partial hearing loss in the right ear. Even now, it's not entirely corrected, and now he's 9 years old. The signs which you said, like the teeth protrusion, all that is visible for him, and even the hearing is limited for him in the right ear. He doesn't hear entirely the words, the start of the words. So is it too late for him for the surgical process?
No, not too late. Okay, first you have to get an X-ray done. You find out how much, how enlarged is the adenoid. Okay, get a hearing test again, or get the confirm with the hearing test whether there is some fluid accumulation. Okay, fluid accumulation can be, I told you, the tube gets blocked and there can be fluid accumulation in the ear, middle ear. Okay, this portion, there can be fluid getting accumulated because this tube is getting blocked. Okay, so if there is fluid accumulation, this can cause decrease in hearing, because the sound is not getting conveyed properly to the bones, inside the bones which cause hearing. So what you have to do is get an ENT evaluation, confirm whether there is fluid or not. Fluid can be confirmed by two ways. One is by otoscopic examination, that the doctor sees through the scope, or through the camera, where they can see and they will tell whether it is there or not. Otherwise, you can get the tympanometry. The test is called tympanometry. Okay, that test the audiologist does for checking the fluid is there or not. The middle ear status is assessed using tympanometry. So we assess how much whether fluid is there, the tube is working, the tympanic membrane is working or not. So first we have to see what kind of hearing loss is there. There are mainly two types of hearing loss. One is due to the the conducting pathway is blocked. This from here to here, the tympanic membrane, the ear pathway is blocked, or the bones, which is it might have able to see. Okay, so these are conductive causes. The other thing is the partial loss can be due to the hearing machine. So this is the cochlea or the hearing machine we can see here, or the nerves. Okay, so if the hearing loss is due to the conducting pathway, most commonly, if there is some suspicion of adenoid, then that can be the same reason. Okay, if the partial hearing loss is due to the nerve component, sensorineural or nerve component, neural component, okay, then that's something different. You might have to get a hearing aid maybe, or if we have to assess how much hearing is lost. Okay, so if the conducting pathway is the issue, maybe there's fluid collection only, then get it removed. Okay, there are several techniques. Once we remove the adenoid, sometimes it gets corrected by adenoid itself, but still we will take out the fluid by giving a small nick in the tympanic membrane. In the tympanic membrane, we will give a small nick and take out the fluid and relieve the tension there. The conducting mechanism has to be re-established. Okay, this is if it is fluid accumulation and the patient is undergoing surgery. Otherwise, if there is no need of any surgery, only fluid accumulation is there, we will give a course of medicine and we will see for 1 month how he is responding. The partial loss. If he is not responding, the fluid is not going, because once if it is a long-standing fluid accumulated, if the fluid accumulated stands for a long time, then it becomes sticky. Then it will be difficult to relieve with medicine. Then we have to put a small nick in the on the tympanic membrane. Then we have to suck it out. We have to take it out. The fluid, the jelly kind of thing. We have to take it out, and we will put a small ventilation tube, very small button kind of, very 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 small, 1 mm, 2 mm, 2 mm, 3 mm thing. We have to put it. We will put it there so that no more fluid gets accumulated there. So that we have to identify what is the cause of your child's partial hearing. If it's a neural cause, if it is because of the nerve or the cochlea, then we can use hearing aid. So these are all correctable. For kids, hearing is very important because the language develops only if the child hears well. Okay. So it is not too late. It's very good time. You have enough time to get it corrected. If he or she is having the adenoid issue, then correct it both. If already there are teeth protrusion and all are there, then don't delay it, and don't want the child to face the consequences. Finish it off as soon as possible.
Doctor, during this time, like now, this even as the pandemic is not entirely done, so the mask, wearing the mask and all, how does it affect the breathing at that time? Because with this condition existing, he is continuing with the mouth breathing. Even the mouth is never like he's not able to even close it. It's all automatically. It's just opened. It's never closed. So with the mask on, how will it affect his normal working? Because now it's only offline classes just going to start. So I'm not very sure how he'll be able
Mask
to go
doesn't
with
decrease
the
much, mask doesn't affect much of the breathing. It increases the workload for breathing, but it does not affect that much. Okay, and especially your child might be using the mask while he goes to school. Maybe like now it started, the schools are reopened, so you can send the kids, but it won't affect much. Okay, only thing is the child needs to take up a lot of effort for breathing. Okay, like most of like his energy will be more diverted for breathing. Work of breathing will increase. So better you, like, the pandemic is not finished, but you can get, like, the nose can be cleared by very soon. Well, like, by, if I, like, from what you told, I feel your child is having the adenoid enlargement. So get it corrected by this vacation, during this vacation time itself. So half of the, like, obstruction can be removed. By that time, most probably this mask thing and all will come out. I don't think this like, we are kind of getting out of the pandemic. So and children also, I don't think they will be bearing all throughout the day in the class. So
Thank you, doctor. Would you be sharing your contact details or some info here?
You can contact Shruti to take a session with Adil, and everyone, those who want to have a session with Dr. Adil.
Okay, thank you, Maria.
Shruti, can you please post your number here? And the session with the doctor will be free to those who are subscribers, Green subscribers. Others will have a fee. You can inquire the same with Shruti.
okay.
So
My daughter always comes me of one nose block every time. She tells that it is never open. What to do? She tells there is a slide when coming in the nose. The nose is closed even if she doesn't now have cold. Okay, so first we have to see like, how old is your kid? Okay, first of all we have to know how old is your kid. If the daughter is more than how old is your kid? Sura baby, 11 years. Okay, so I told you nasal blockage can be due to many reasons. Okay, maybe not due to adenoid, because adenoid causes blockage of both the sides. Okay, so a unilateral, like one-sided nasal blockage. So the most common thing will be the nasal septal deviation. Okay, then septum, or the what we say, the nasal septum. So assume that this is a nose, inside part of the nose. So there is a like separation which separates the right nose from the left nose. Okay, so this triangle kind of thing is my nose, and there is a separation which causes the nose, like, which separates the right nose and the left nose. Okay, so if there is a bend, okay, imagine that there is a bend towards the left side. My left side, it is actually, I don't know how we are seeing it. I think the image is good. Okay, so towards the left side, then what happens is it can lead to blockage in the left side alone. Okay, the right nose will be fine, but the left side will be blocked. It can be, there are several types of septal deviation. There can be S-shaped deviation or unilateral deviation. There can be a small bony growth also. It is called spur. Okay, so that is septal deviation. Okay, if you so that has to be corrected. That has to be corrected to open up that nose. Okay, so for septal deviation, we have to correct it surgically. For surgical correction, the child has to attain growth maturity of like bony growth, or like bony maturity has to be completed, which is approximately 18 to 20 years. Once a child has attained his or her complete age, age till which like the bone growth happens, you might know that from by 18, 19, 20 years, the bone growth stops. After that, they won't increase, the height won't increase. No. So after that only we do the nasal septal procedures, because Once you correct it, if the child is growing again and again, the septal, the separation, the bony and cartilaginous part, it will again deviate. So we don't operate before the age of 18, 19, 20. It varies from children to children. So the bony maturity is the cutoff if the nasal septal deviation is there. The septum is the separation between both the nostrils, so it's extending till the back side. Okay, so there can be any deviation towards right, left. So we have to first of all clinically examine. Okay, we have to clinically examine and tell what is the mass which is coming. Like you have mentioned that. Is it because of some growth? I know that's the doubt majority of the parents have. Everybody is having. I also had before joining MBBS or ENT specialty. I also had this. Something is there inside. Like we normally see such kind of things. So in children of 11 years, that's a female. That's a very uncommon thing to have. Okay, very uncommon thing to have some growth inside. The most probable thing will be the turbinate might be hypertrophied. There will be due to allergy. There might be some kind of allergy. Is not always sneezing and nasal discharge. It's not always allergy. There are some allergies which cause only nasal blockage. Nasal blockage can be the sole symptom of an allergy also. So it's not just it's not necessary that everybody will be having nasal discharge and sneezing all the time. Okay, so maybe she might be having allergy. Because of that, the inferior turbinate, I showed you that a picture of the turbinate might be enlarged, which might be misunderstood as a growth. If you have doubt, then get it confirmed by an ENT. Like you have to get it confirmed by the ENT doctor itself. Because nasal growth, people won't get, like all the doctors, all the specialty, they won't get to see the nose always. Inside the nose, inside the ear, they have read or studied during their posting, but we see it frequently. So it's very easy for us to identify because we see it in a day-to-day basis. So any kind of growth, polyp, nasal polyp, etc., we can identify it very easily, and we don't need to do an endoscopy also. Like it is required if there is a severe deviation. Endoscopy might be required, but I don't think that might be required. But first we have to get a normal ENT examination, and this can be because of the she is allergic, then most probably because of that alone. Allergy and nasal septal deviation causes majority of the nasal blockage, so it's not a big deal. It can be like controlled using medicines, and if it is not resolving by medicine, and if there is ample deviation, can be corrected once the child has attained age. Surgery for adenoidectomy. Adenoid surgery is called adenoidectomy, and the septal correction, if you're asking about septal correction, that is septoplasty. Septoplasty is for septal correction if it's a deviated septum, and surgery, if you are asking, that is called adenoidectomy. Okay, adenoidectomy. Adenoidectomy can be done by many ways. So and the latest is adenoidectomy. A D is missing. Okay, please add the D. Okay, coblation adenoidectomy is the latest technological advancement in that. Okay.
Shall we wind up? Is there any more doubts?
Okay.
Doctor, I meant the surgery for the nasal septum, the deviated nasal septum. For
Septoplasty. Septoplasty.
Septoplasty. Okay. That can be that corrects the situation entirely for the breathing issue.
No, like I told you, so, like you are asking for the kid or for adults.
No, it's for my teen, 14-year-old. Hers is actually post-injury.
I didn't get you.
It's like she has this issue not by birth. It's owing to an injury in her childhood,
then
where face got smashed, and that's why it's still it's like 7 o'clock. The nose looks like.
Okay, so that is something else. That's not exactly septal deviation. Okay, so if the nose getting smashed, or if there is some external injury, this causes the external nasal framework also to change. Okay, it's not just a septum. Septum is not, it's an inside thing. We can't see it from outside. Okay, if her nose is looking is a little bit deviated from outside, that means her nose is also deviated. That's not the septum which is deviated. Septum is an inside like separation, I told you. So then if the nose is deviated, then we have to get a rhinoplasty done. So if the septum and the nose is deviated, we get a septorhinoplasty. I have posted it here, septorhinoplasty. And it is mostly done once the child has attained, because I don't think she has faced the injury recently. Okay, what happens is if the child is getting like hit by something or some kind of injury, if the nose nose is like the bone is broken or the framework is changed, then you have to get it corrected at that time. If it is not done at that time, you have to wait for 2 weeks. The edema, the swelling and all, everything gets settled. By 10 days, 2 weeks, you get it corrected. And if it is not corrected by that time, wait till the child becomes an adult, get a septorhinoplasty, also called nose job. Okay, so that's kind of a plastic surgery, or an ENT specialist does that, or a plastic surgeon does that. In that, we get the external framework, the external nasal framework corrected, and at the same time, the septum, if it is damaged, that also needs to be addressed. So outside, if it is done, that is nose correction, that is called rhinoplasty. The other one is the septoplasty, which is the correction of the nasal septum. Okay, so both are different. Okay.
Adil, it was really a concept building class. Thanks a lot for that, and for patiently answering the questions all throughout these 1 hour, 1.45, 1 hour and 45 minutes. Thanks a lot, Adil. I hope your doubts are cleared, and if you want more, if you want to take a further talk with Dr. Adil, please go ahead and message Shruti. And yeah, coming up next month, it's summer and also vacation time, and you can see all summer vacation hashtags everywhere. And our theme for April is summer and vacation. We'll address summer health of our children, vacation time activities to engage them, and also since it's vacation, we know that you'll be pushed to the maximum of your patience, and we'll have a session on anchor management for parents. And all the sessions are free for our subscribers. Those are non-subscribers can message Shruti to know the details of the same. Okay, so see you all in the next session. Thanks a lot for joining. Thank you, Adil.
Okay, welcome. Thank you so much.